Welcome. My name is Dr. Richard Severin. I am a physical therapist and physiologist based here in Chicago. I am faculty at Baylor University and the University of Illinois at Chicago, where I am finishing my PhD. I'm really excited to be on this interview.
Hello. This episode is going to be awesome. Most people do not know what DPT means when I say it. So I have an expert, a legend in the field of physical therapy himself here, ready to join me to educate everybody on what it means and what it takes to be a DPT, and give us some updates on some really cool stuff that he's doing. So thank you for joining us, Rich. I want to go ahead and elaborate more on what DPT means, what it takes, what the path looks like. So if you could tell us a little bit about your background and how you got to become a doctor of physical therapy.
Yeah, it's a great question. So the doctor of physical therapy degree is the entry-level degree for physical therapists practicing in the United States. It's a in most situations, it's a 3-year doctoral degree or clinical doctorate degrees. So, akin to clinical psychologist, pharmacist. You can even throw in medicine as well. They're all post-professional degrees. And then, of course, you have your bachelor's. You can earn your bachelor's degree in anything, just like in any, prerequisite for any graduate program. You apply to physical therapy school. I think we're now at 240 some programs across the country, typically smaller programs. Yeah. It's interesting. There are less slots for PT school than there is medicine. Like our programs average around a size of about 40 or so students, give or take.
Yeah.
And then you've got some as small as like 25 and some as large as about 100. So, but yeah, that's the training. There are programs that are accelerated. So the program I teach for at Baylor University is an accelerated program. It's a 2-year degree. So it's just to get through things a lot faster. It's like drinking, water through a fire hose sometimes. But
is that sorry to interrupt, is that a direct matriculation situation, or like they complete their undergrad and then do 4+2 kind of deal, or what?
No, it's not a direct admit. It's a separate, post-professional, graduate program, but it's just accelerated. Same requirements. It's just they get through things faster. They do some coursework over their clinical education, like their rotations, and then they don't really get breaks. So yeah, that's the other side. I was just talking to a student who was interested in our program the other day and today, actually, maybe like an hour before this call or interview. But yeah, that's the traditional length is about 3 years. But there are even some programs like I think Army Baylor, our sister program.
Yeah,
one of the most prestigious programs in the world. They're 2.5. So it varies. Credits for doctoral degrees are all based according to the credit load. So as long as you meet that, you can justify the whether or not it's a doctoral level degree. So yeah.
And the accelerated is just it sounds like a hardcore year-round commitment.
Yeah.
Both classroom and clinical, I imagine.
Yeah.
Yeah. And this has clinical, well, we can get into this later actually, because I want to hear more about what you did and what your schooling was like. And maybe if you could just elaborate on that more. I know you're an educator yourself and you're on staff now teaching that accelerated program, but what did you completed your undergrad, and then tell us how it went after that.
Yeah. So, I started out my undergraduate degree was in kinesiology, which is the study of human movement or movement science. So that, most PT programs, students are coming from that background. And it just makes sense because that the undergraduate program in kinesiology for most, it's interesting because kinesiology means things very differently around the world. Like kinesiology in other countries is a bit of like an alternative medicine practice kind of thing. Like,
really?
It's more it's technically applied kinesiology, but that's like kind of woo nonsense stuff.
Okay.
But kinesiology in the United States is like a movement science, health science, kind of exercise science.
Yeah.
Major. And why it's got a nice connection to PT programs is because you take the anatomy, the physiology, the exercise physiology, the biomechanics, the sports psychology, the abnormal psychology, usually biostatistics are usually core elements of those majors. And those are all the prerequisite courses that you have to have taken for PT school. But we do get a decent number of students. Even when I was a student, we had kids, coming from business majors or finance majors. I always love engineers, on our programs too, because they always have an interesting mind. But most people in the field are coming from a health science background, just because the nature of the profession involved. I mean, the foundation is exercise and human movement. So you kind of have to have an understanding, or at least an appreciation for it. And then you're training as a PT student. Most programs will start pretty similar to med school, where you're going to be in your foundational sciences. So for us, it's we do a lot of anatomy. Med schools, by and large, are kind of phasing out anatomy as a priority and favoring more biochem and stuff like that.
Sure.
So we're, I think you're usually there for a whole summer for anatomy, or at least a full term in the fall in anatomy, 6 credits or up to 8. And then your foundational physiology, and then obviously your intro to PT kind of stuff. And then you transition more to we call it clinical management courses. So you're getting into the basics of examinations. So strength testing, neurological examination, cardiovascular examination, stuff like that. And then you get into specialty management courses and different systems. So the 3 main systems that we view kind of the human body through in PT is obviously the musculoskeletal system, which most people are familiar with when they encounter PTs. The neurological system, and then the cardiovascular and pulmonary system. And then there's, take some coursework in pediatrics. You take some coursework in geriatrics. There's some pharmacology in there, some imaging thrown in there. And the pharmacology is more like understanding how medications impact clinical presentation, and how that affects human movement. Right. So that's the underpinning of everything we do is how well someone moves, and, assessing that, providing interventions, and in our assessments, determining what physical or body structure impairments is a weakness. Is it endurance? Is it a balance issue, a motor planning issue, a coordination issue, a sensory deficit, a respiratory system issue, a cardiovascular system issue, that we can address or intervene. As well as determining if a patient's medically stable to be in our clinic to receive our services, or do they need to see another provider and refer them to a physician, surgeon, of that nature. So it's really been an evolution, like the profession in many respects. It's interesting because our professional organization, the APTA, just had their centennial celebration, the 100 years of the APTA, which really marks the formal kind of emergence of physical therapy in this country. And that kind of was born out of an earlier field called rehabilitation aids, which really worked with people post-World War I, their injuries, the polio pandemic, and other stuff like that. And it was more tech-based, like they got an order, and they followed the order for whatever exercises and stuff like that. And then as the profession evolved, like other fields, like pharmacy is the same way, nursing is the same way. As their training, as their profession evolved, they've taken a more autonomous role, which is great because, in med school, they're not going to have a lot of time really to focus maybe on exercise prescription, movement assessment. Like that's kind of what, it's nice to have a profession that does that, just like it's nice to have a profession like pharmacy that they know medications, like the back of their hand, right? That's kind of what they do. So we play that.
Yeah. Sorry to cut you off. I mean, you're absolutely correct. I just wanted to reiterate, there's a reason for all of these specialists, and the need for PTs in literally every department of a hospital or every area is huge. And like you said, there's no shortage of information that needs to be learned before you go in and fully assess somebody top to bottom and see what their needs are, and then tackle the issue at hand. And I think that's interesting. I don't think people realize that. I think first off, a lot of people don't even understand how far-reaching physical therapy is itself. So that's really cool that you were able to explain that. I just wanted that you brought up a really good point. So sorry to cut you off there.
Yeah, no worries. Yeah, and the point I was saying is that when our perspective, just like other disciplines, are valuable to that interdisciplinary medical team. We're seeing medicine broadly move towards, where you've got everyone has a different angle or different perspective on the care for that patient. The hospital setting, especially, PTs that where you see that collaboration happen so often. You're even seeing it, kind of more in your field. You're seeing a lot of PTs in the emergency departments too. Like that's a growing area as well.
I heard that, and I don't know if this is true or not. Maybe you can confirm, but somebody was telling me that the need is so great for PTs in certain areas around here that certain hospital systems, like I said, have such a need in 24-hour services such as EM that they are paying a full 40-week salary to PTs that will work only weekends. Like Saturday and Sunday, you get your full week's pay.
I haven't heard about that. That sounds pretty dope, though. That's pretty awesome.
Yeah, I heard the need is getting pretty great, and there's some pretty unique opportunities.
Yeah, well, it's a reflection kind of our healthcare system, which is a little bit broken. We need to address some gaps there. But so a lot of people, you know this because you see it every day. A lot of patients, use the emergency room by no fault of their own as their primary care, right? So, and the unfortunate thing is, that prevents true emergencies from being addressed. Right, because an emergency room, by law, I don't think they can't refuse care in an emergency room. So you get people walking in there with like back pain. It's like, okay, were you in a car accident? Like, no, like my back hurts. So what that helps, and there's research that supports this, is having a PT in the emergency room not only helps offload those kind of cases. They can triage, again, because we have a lot of training. I teach some of this in our coursework here, both at Baylor and at UIC, on medical screening. Again, determining what is this patient appropriate to be seen by me, or they need to be seen by someone else. And
that can prevent a lot of expensive and unnecessary procedures, and and
triaging in the emergency room, and then the lower, and you see this on your angle as well, the lowering the amount of prescribed opioids too, because we can do certain things with different techniques or different, exercise-based interventions to address back pain. And then the other things too, nystagmus, or not nystagmus, vertigo, right? Different things we can do with that. So it's a growing field. And that all comes again with like the evolution of our profession and our training. Like we've gained and embraced these new skills and knowledge and scope of practice, and it's adding in value to systems. And then part of it's just trying to find ways to get our expertise and knowledge in other areas of medicine that lend itself well. And emergency rooms is a classic example of that. And we're seeing that, around the country. It's a great service.
And that is, just a very, very small portion of how large the field of PT is, and how capable DPTs are. So that was, just one really good example of a large pool. I feel like there's a lot to be done, and a lot of things that you're capable of doing as a DPT. So this is good, because I don't even think, there's so many acronyms and abbreviations in medicine. You say DPT, people have no idea what you're talking about. So
it's a problem we're fighting as a profession, is trying to get, people to be aware of this. Because when you say PT, sometimes the people, they think personal trainer. It's like, nah, training's a little bit different than a personal trainer. So,
very different.
Yeah.
So that makes me think, is this new? Is this profession new?
So physical therapy, I mean, depends on how we define it, right? Because there's stuff from back in, in antiquity where you saw people doing what we would consider rehabilitation. And I mean, the history of medicine in general is pretty murky, like what did people do or not. But I trace things back really to like that post-World War I period where, like, again, like that rehabilitation, reconstruction aids. And then you had your first formal training programs at Walter Reed, as well as for the U.S. Army, in other places. Northwestern was one of the first programs here, and like other professions like nursing, like pharmacy. I think UPenn was an example of this. UPenn had we call it a registry program or certificate program where you get trained basically at the hospital. You don't see that anymore for any profession, like where you get your training, your diploma, your certificate from the hospital. And now you go to a university for it. But the DPT as a degree has been around since 1996 at Creighton University. And I believe that was a post-professional program, because for many years, just like medicine, which I think people forget, in other professions, the degree in medicine historically for many years was a bachelor's degree. And then it only, maybe in the past, really like 57 years, did it like formally switch to like a true, just like you had a separate undergraduate and then a separate post or graduate medical training. And pharmacy was the same way too.
And moving beyond that, moving beyond the development or the just formalizing the medical school training and separating it from undergraduate studies came the birth of a lot of new specialties as well. Because from what I'm told, the emergency department, emergency medicine itself is a fairly new specialty, and it was not uncommon in, I think, maybe the 70s that there was maybe an OBGYN picking up overtime, rotating through the emergency department. It was just any general doctor, depending on the hospital, coming through.
Medicine was a wild place before, like, maybe the 90s. It's still a pretty wild place, to be honest with you. And if you go back even like to the 20s and before then, like people avoided medicine because of like the outcomes weren't great. The training wasn't necessarily like standardized until the Flexner report came out and was like, we got to shut down some of this craziness.
Yeah.
But yeah, to the DPT, the first one, 96, post-professional. And then most programs around that time started rolling out entry-level DPTs. At that point, most programs were a master's degree. So we went from, registry to a bachelor's degree, to a master's. The move probably should have gone right to the DPT, because the master's of PT had way too many credits to be a master's, but they kept it there. And then part of the vision of our professional organization, the American Physical Therapy Association, was that by 2020, every program would be an entry-level DPT. And by the time I had applied, this was back in 2009, I got in 2010, there was all but one program that were the DPT, just one program. And that was, I believe, Florida A&M. And then they eventually became DPT for entry level in 2015. And then since forward, 100% are DPT, all of them are DPT. And that will be the degree going forward. So I'd say probably the past 15 or so years, it's been the primary entry-level degree for everyone. And if you look across the profession of everyone practicing now, we're probably over 60%, 65% of everyone holding a DPT, or we have a transitional degree. So people we're given the option to go back, get additional training, from their masters and, move up to the DPT. And then we're hoping, and we project probably the next 10 years, everyone practicing as a PT will be a DPT.
This is new. This is, now I understand why people are confused or don't know what DPT stands for. This is, there's a lot of catch up to be done.
Yeah. We're still in a transition period too. So that's what it is. Yeah.
Yeah. So when you were completed your training and your was it a 4-year program, the DPT at
So my University of Miami is where I went to PT. It was a 3-year program.
3-year? Okay.
And that's consistent for most programs across the country. It's 3 years, and usually your last year is a clinical year for the most part. You're just doing clinicals,
right?
And then and the other thing is too, like, which is kind of neat. Like a lot of programs now are, there were a handful that were, affiliated with their medical school. For many years, Miami was a separate entity within the graduate college. And then I think, 2004, we became affiliated with the medical school. So now like my degree is graded by. So you're seeing a lot of that too, which I think is kind of cool. You're seeing these other programs like built around each other within the same umbrella medical.
Yeah. I like that collaboration.
Yeah.
Did you take a board exam? Is there a test when you're completed?
Yes, there is the National Physical Therapy Examination that everyone takes. So, to gain access to taking that, you have to complete your DPT, and your program has to give you your stamp of approval. Take that. It's like a 6-hour. It's a long test. You go to testing center, and then you get your scores back, and then you become licensed as a PT. So you'll see in a lot of PTs when they sign their designation, I would sign it like Richard Severin, PT, DPT. So my license is PT, but my degree is DPT. It's weird because like physicians just put MD because like your degree and your license is the same designation.
Right.
I guess technically like you can have an MD and like not get licensed, but like that doesn't really happen too often.
No.
But so for us, because we still have people that were like bachelor trained, master trained. I mean, I think there's maybe like one person left from like the registry, like way back in the day. They're probably like 80 or something like that. So
yeah,
it's PT. And then I think the plan is once we're close to about 95% or 100%, we'll just make the designation DPT, just like we see with everywhere else. Because like it is kind of weird seeing that. Like, why do they put two things there each time? So
yeah, it seems a little repetitive.
Yeah,
PT,
it is.
PT. Yeah,
it is.
Yeah. So I know you have a large pool of experience. You've been doing this for quite some time. I mean, I remember talking to you in Tez's apartment on Spring Garden back when you first got in, and that seems like a lifetime ago.
Yeah.
But once you completed school, did you partake in any specialized training, like a residency or fellowship, or?
Yeah, I did. So, and that's kind of the cool thing too. So, there has been physical therapy, the concept and the design or the pathway to specialization, formal board specialization in physical therapy, has been around since 1981. The first specialist got granted specialization in 1985. Is actually, in fact, taught by one of them at University of Miami, Merrill Cohen. All three of them hold the specialization I have in cardiopulmonary. And then residencies and fellowships existed around the same time where they weren't necessarily connected to a formal specialization because they didn't exist yet, but they had training. But I did go to a cardiopulmonary residency training program. And we've got, I think we have 10 or 11 specializations, and then there are many residencies that are connected to one of those specializations. There are also other residencies in different domains that don't necessarily have a board specialization yet. Like we have one, for example, in acute care. We have acute care residencies,
right?
But there's no acute care specialization. But like it's to prepare you for that kind of area of practice. Those aren't mandatory. There aren't really enough yet. They're highly competitive. Like, for example, when I applied to a cardiopulmonary residency, at that time, there were 4 total programs around the country. Only 3 of them took students or new graduates, people who just graduated from PT school. And there was a total of, let me count it, hold on. 1, 2, 4 spots naturally.
Wow.
So I got one of them.
Wow. That's
yeah.
insane.
It's pretty insane.
And it sounds like there are just a plethora of specialties. Once you complete DPT, you can, take it and do what you want with it and hyper focus on certain areas.
Yeah. And the cool thing is, and we've had some discussions about this recently in some of the forums and platforms that I oversee. But yeah, it's the great thing about the PT. It's a blessing and kind of a curse to a certain degree. And but you graduate with a broad license. Like technically, if I wanted to legally, under my license, I could go treat pediatrics today if I want. I could go treat and bill for a pediatric case. It would probably look a little funky on a third-party insurance. Like, why is this guy randomly putting a pediatric case or a neuro case? But my license grants me that. Like I can, which gives you flexibility if your interests change or for lifestyle changes. So you don't. Specialization isn't mandatory. A lot of people, if they don't do a residency, which is the purpose of that, really, we view it. It's not just to get a pathway to the specialist exam, because if you do complete a residency or a fellowship, an accredited one, you are given the right to sit for the specialist exam in that setting or a related one. Like someone who did an acute care residency could do a geriatrics, could do a cardiopulmonary residency typically. The purpose of their programs are like mentorship and refinement of practice and clinical reasoning. But if you don't do that, you can still just sit for your specialization. You have to amass, 2,000 hours in that setting, and each specialty has a list we call the designation of specialty practice, which lists the conditions that you should be seeing routinely. So you have to justify, list the conditions you see. You submit that to our national board, the American Board of Physical Therapy Specialists, and then they grant you approval to SIFR. So there's a couple pathways to specialization if you want to. And the unfortunate thing is, like a specialization, like a cardiologist, for example, if they become board certified in cardiovascular medicine, they are given access to different procedural codes. Like they can do an angiogram, they can do a cardiac cath, and different stuff like that a family medicine physician can't do, right?
Yeah.
However, that doesn't change, except for a couple specialties. Like we have an electrical diagnostics, so they are given license to do nerve conduction velocity tests and different stuff like that. There really isn't like a major difference in your license or scope of practice in most settings. So it's more just a reflection of your skill to your employer, patients you're trying to interact with. But we're working towards maybe addressing that. Like your specialization should probably come with something directly as an incentive.
Yeah,
but it's a good way to kind of. I think I encourage it because it's hard to be really good at everything. It's kind of good to get focused and being really good at one or a couple things. So,
well, I mean, I feel like you do 9,000 things in the field of PT.
That's probably true.
You're always grinding, but your cardiopulmonary specialty sounds awesome. Mm-hmm. What have you been doing any work with that recently, or do you use it every day, or how does that fit in?
Yeah. So, and my story was a little bit funky too, because I did 2 residencies. I did one in cardiopulm at the VA in Madison, Wisconsin, which is dual affiliated with the University of Wisconsin-Madison. And I came to UIC to do an ortho residency, but it was more on their researcher track, and then transition to my PhD here at UIC. And then, but I used my specialization often. I developed a bariatrics rehabilitation program here. So we work with patients before and after weight loss surgery, which, all those patients, from the vast majority of those patients, have some sort of cardiovascular pulmonary system involvement in terms of their limitations to exercise and be active, which is absolutely the purpose of our clinic. And then my area of research is in cardiorespiratory physiology. So yeah.
That is really, really cool. You know what? I don't I didn't even realize how many specialties there were moving past PT school. And the bariatrics portion that you just mentioned, is that also a specialty? Is that something you can focus on?
So it's not a defined specialty. So we've got, again, I think 11 or 14 like established specialties by our specialty board, which is like recognized by the National Board of Medical Examiners, which are, you've got cardiopulmonary, geriatrics, pediatrics, electrical diagnostics, pelvic health. So people working with people like post-pregnancy and stuff like that.
Yeah.
Neurology, sports, and oncology. And I'm probably forgetting another one, but so that's the specialties that we have. And there's a couple upcoming. Bariatrics is just the clinical population that I work with, which is nice because it kind of combines my board specialization in cardiopulm and then my additional training I did in orthopedics, because like a lot of them have musculoskeletal issues.
Yeah. So it's kind of a nice. Maybe we'll make a specialization in it in the future. Because there's very unique things with that patient population, but seriously. And I know you guys train in your program to see anybody and everybody. That's a part of the training and becoming a DPT is what it sounds like. But to be able to hyper focus on one particular area of interest is pretty cool. I think that's really fascinating. That cardiopulmonary is one of the specialties that sounds like it's really involved and actually far-reaching. You just mentioned a small portion of the capabilities, I'm sure, or the possibilities I'm sure you have with a cardiopulmonary specialty.
But and the way we view it, especially since they don't come with like a change in scope of practice, it's really just a reflection of because you could go with if you have a sports specialization, you could still practice in a hospital and see those patients, or a neurological specialization. We view it as just you're really good at, assessing how those systems, impact human movement. Like a cardiopulmonary specialist PT is knows those systems cold and knows how to assess, and then potentially treat patients with cardiovascular and pulmonary limitations to human movement. The same thing with an orthopedic specialist. They're an expert in musculoskeletal impairments or patients with musculoskeletal disorders that prevent or impair human movement. That's I think the general way we view it in terms of, because again, it's not like you're pigeon, because an orthopedic specialist could still work with a patient with neurological conditions under their license. And sometimes that having that specialty training, is valuable to patients of a multitude of different diagnoses. So we view our patient populations and how we, interact with patients or treat patients by not so much by their health condition, but more their body system impairments or their limitations or activity limitations. It's a little bit different.
You previously mentioned research. Is this, is that something you can just hyper focus on? Can you finish your DPT program and solely work in research?
Yeah.
Really?
You absolutely can. It'll be harder to do because as of right now, so I went to check, there are 9 specialty areas. I don't know why I thought 14. There's 9. Cardiopulm, clinical exercise physiology, geriatrics, neurology, oncology, orthopedics, pediatrics, sports, women health, and wound management. That was the other one.
Oh, okay.
So the research question, like any profession, there's always, individuals who, pursue research to build the knowledge base of, the treatments, the assessments that we do as clinicians. It's kind of hard to do that as a standalone degree. If you want to, because if you want to run a line of research, you need funding. While we do have, funding from our foundations, because we have the Foundation for Physical Therapy Research, different organizations. And if you want NIH funding, you typically have to have we call a terminal degree,
right?
Which is weird because though DPT is the highest degree for a physical therapist, highest clinical degree, they don't recognize that. NIH and other organizations, NSF, DOD, they don't recognize that for research purposes. So you need to get a PhD or a doctor of science or some other, which is strange because like an MD does not need to do that. Like if you've graduated an MD, like you can go just do research. Same thing with pharmacists as well, which is strange because like med school doesn't necessarily train you to be a researcher.
No.
And neither does pharmacy school, but it's just, we're working on it. We're hoping to make that like a
that would be, I think that would be a step in the right direction.
Yeah, I think so too.
Is the research being conducted typically performed by educators? It seems like they kind of coincide.
Yeah. It's you'll see most PT researchers that are affiliated with some sort of academic or at least a large hospital system, usually a university-based hospital system. It's just, though you do see some research coming right from the clinic, however, you need to have an IRB, which, universities have. There are private IRBs people can, pay to use, but it costs a ton of money. But yeah, so most times it's your faculty at, in a physical therapy program or a clinician affiliated with a large, hospital system. Like I have colleagues, for example, at Johns Hopkins, they aren't true teaching faculty in a certain sense, but they are involved in clinical research there as part of their job descriptions. But
I just feel like, the people conducting the research and making strides to advance that particular field of medical practice should be, if they're willing, should be directly involved in the education as well, because, they're at the forefront. They're learning all of the past, current, and future material.
Yeah. So. Yeah. And that's why you end up seeing it in most professions, the educators and research go hand in hand because you're supposed to stay up to date. With clinical programs are unique though, and you'll see this with medicine as well. You'll have faculty in med school that, do more traditional academia. They're doing research, they're writing and publishing often. And then you'll have clinical faculty that are more in the clinic because it's probably better for people to teach you clinical skills, beyond just basic examination stuff, that are still kind of doing it, right? Or at least have them involved to some degree to provide that instruction. So we do that here in our PT programs. I'm still in the clinic in a much lower sense than I was at the start of my career. I don't necessarily foresee myself even, staying in that smaller, we'll see. I don't know. I like working with patients, but
sky's the limit. Yeah.
Yeah. We bring in, adjuncts or secondary faculty who's probably more full-time in clinical practice that comes and helps with some of our lab activities to learn how to teach our students how to do certain assessments and stuff offer that perspective from practice.
I think this is a pretty good insight into how diverse the field of PT is and how much DPTs can do. But I also want to dispel any myths. So are there any common misconceptions about PTs or DPTs in particular and things that we can get out of the way and correct right now? So anybody listening can say, oh, wow, you know what? I thought that as well. And that was incorrect.
Oh boy, there's a couple of things that we get often that physical therapists only really work because the most people, their experiences with a physical therapist is in an outpatient orthopedic clinic, typically, unless something really goes wrong with you, or you have a stroke or spinal cord injury, right? Or you get heart failure, right? Or COPD or something like that. You end up in a hospital. So, which I guess is true for other professions. We treat more than just joints and stuff like that. Like I said, my specialty is cardiopulmonary, and there are people that work with kids, right? I mean, we see the full spectrum. So that's one big thing. We have a broad scope of practice. The other is that PTs, like, you need to get a physician's referral to go see a PT. In every state, we have some form of direct access, meaning that you can go see a PT. And this is typically for orthopedic issues, like if you have a back pain issue or a neck pain issue.
Right.
And in Pennsylvania specifically, you can walk into a PT clinic without referral and get seen that day and for up to 30 days. And some, which is usually enough to manage whatever issue you have. Some states, it's a little bit more or less, but in every single state, there is a direct access law that is granted to PTs for that. And part of our responsibility is, again, that medical screening. Okay, you're here for back pain, but this is actually an abdominal aortic aneurysm. You need to go to the hospital, like an emergency room immediately. So like that's part of our training to recognize that. The other is that we are not personal trainers. We are not the same thing. A personal trainer gets a weekend certification. That is 7 years of training, 4 years, bachelor's, 3-year doctoral degree. We are a doctoring profession. So that's probably the big one. And then you may see this in a lot of clinics. People just get hot packs, ultrasounds, stuff like that. Like, that's not PT. That's a modality that we don't really do a lot of anymore. That doesn't really do much for most people. But yeah, I'd say those probably the biggest myths about PT.
Yeah, I mean, those are huge. I mean, if you're listening and you thought a PT is there only for your joints or for your minor injury, you're wrong.
Or put some hot packs on you, or some,
you're absolutely wrong. And if you think you're not capable of walking into an office where a DPT can see you, you're also wrong.
Yeah.
So,
and the big thing is too, like, always just check. I mean, we'll always check to make sure. Some insurances are a little funky. Like you may still, if you're on like a managed care plan, you might need to go through, and that's for every specialty. But you can view PTs as a specialist, just like any other discipline. But yeah, like if you got garden variety back pain, like you woke up and your back is stiff, like don't wait. I mean, I don't want to come off rude or impertinent, but like your primary care physician's just going to send you to a PT anyway. Like that's why those laws exist. It's like
skip the middleman.
Yeah, exactly. And let them treat stuff like that. They're really good at treating, like, diabetes and stuff like that. So, hypertension, major medical things.
When all is said and done, do you think, and you don't have to go into specifics if you don't want, but do you think DPTs are appropriately compensated, or do you think there's still progress to be made?
Oh man, a lot of progress to be made. Medicare, some of it was, I actually just had a very recent discussions about this on my social media and the groups I oversee. Here's the thing that I think PTs need to do a better job of as a profession. A lot of PTs will work for these corporate chain clinics. You see them everywhere, and I'm not going to name names, where you get you see a lot of patients typically. Your pay is not always that great. And there's money to be made. If you own your own practice and you can generate a consistent stream of referrals, like you can do pretty well as a PT.
Sure.
But for most PTs, pay isn't where it should be. Compensation from third-party payers is not where it should be. And then Medicare at the start of the year, had proposed to cut reimbursement for Medicare. Old people, right?
Come on.
Who need to see PTs pretty often.
Yeah.
They got falls, all kinds of issues that we address. They were proposing to cut all rehab services, occupational therapy, speech therapy, PT, by 9%. And most insurers look to Medicare for guidance. Our professional political action committee and professional organization were able to lobby to get that reduced to 3.5%. But that's still pretty major cut. which makes it hard. So you're seeing this in family medicine too, like every specialties getting the belt tightened a little bit, on reimbursement and have to jump through. So you're seeing a lot of PTs move to cash-based, just cutting out the middleman, cutting out insurance and saying, hey, like, here's our services. We can work with you in the payment plan. Does that always work for everyone? Like the population I work with in Chicago, like most of my patients are on public assistance, Medicaid-based plans. Like we don't charge a no-show fee, or a late fee or anything like that, because they can't afford it. They would never pay it. And it's just kind of unethical to charge people who,
absolutely
plans. But it's, so you're seeing some PTs do that with the onset of mobile health, like telehealth platforms, and being able to you don't necessarily have to have a four walls of clinics. You're seeing a lot of PTs popping up in gyms. So, either as a owner of that gym, so they have the fitness services, wellness services, and then rehab services all within one package, or they're renting out space in that gym. You see this in a lot of CrossFit facilities, and yoga studios and Pilates studios, where they'll rent out a space and they'll work with the athletes or the clients or patients there. So it's a nice kind of ecosystem of health and movement and stuff like that. So you're seeing a lot of that, but it's a big problem. It's a big problem across medicine. Like insurance companies, pardon my French, they suck. Like they're horrible. Like they make life for our patients terrible sometimes, because you pay an arm and a leg in premiums, and then you got to pay like $1,000 deductible to get coverage. Right? It's nuts, right?
Yeah, and it's backwards, and it's. That's a large issue. I think that could take a 2-hour episode in the podcast, just talking about all of the issues with healthcare and reimbursement in this country. Yeah, but that's actually funny you mentioned the gym portion of it too, because I don't know if I told you this, but my favorite at-home workout video is a DPT.
Really?
Yeah, and he's awesome. I forget exactly what he specializes in, but he has a whole YouTube channel. Once I remember it, I'll send you a link. But he is phenomenal. He has a workout channel on YouTube where he talks you through just important exercises and proper form and movement and everything like that. And he's real eloquent. So I love his videos. He's a good dude. Once I remember what his name is, I will absolutely send it to you. It's in my favorites.
No worries.
So one of the questions I like to ask everybody that comes on the podcast is, has COVID-19, the pandemic itself, et cetera, affected you or your coworkers directly?
Oh yeah, absolutely. Even just beyond the clinical status, our education, our students, for all their clinicals, some of them got canceled. They had, if you were in an inpatient facility, a lot of hospitals, skilled nursing facilities where PTs are in as well. Yeah. Rehab hospitals just didn't take any students. They're like, nope, like we're
not a chance. Yeah.
And just, staff on there. So that made things tough for everybody. Our in-person labs all had to pivot to virtual stuff. So, all of our in-person instruction. So fortunately for me, I've been teaching in a hybrid model for about 5 years. So I'm pretty comfortable. I had a bunch of recorded lectures already done, the whole YouTube channel with stuff on there, that I just use for my students. But yeah, that affected stuff. Our lab shut down. I got COVID, in September. Yeah. And then, and I have, friends of mine who are on the front lines of care, like working with patients post-COVID, while they're admitted in the hospital or actively with COVID. So it changed things quite a bit for a lot of people in our profession. And I think, you see those statistics thrown around by people I think maybe don't have a good understanding of maybe epidemiology or just medicine in general. They throw around, then 99% survival rate. That may be true. However, right, like you get sometimes patients with, may survive a condition and have very significant, impairments later on. Like we see this with patients, with any condition.
Yeah.
And, anytime anyone's admitted to an ICU, there's a high risk of developing, we call ICU delirium, ICU acquired weakness, and then a condition called post-intensive care syndrome, which can have lasting effects up to a year, 2 years, and then, all the other psychological ramifications. So just surviving something is not, a guarantee that your life's going to get back to normal. And that's really where we intercede. Like the way we always view it, like your physicians, your surgeons will probably save your life, right? Like they'll keep you from dying and keep you alive. And then PTs kind of get your life back to living, right?
A quality of life return. Yeah.
Yeah.
I like what you said. You might survive the ailment, but at what cost?
At what cost, right?
What's the quality of life moving forward?
Yeah. What does that life look like, right? That's been saved, right? So that's where we played a huge role, as well in just managing like patients who are on vents, like getting patients up and helping with different things with that too. So it was I have friends who are still, seeing decent amounts of COVID patients in hospital. I think hopefully numbers will start getting better, but yeah, I mean the start of, April, mid-March when it rolled out, things were pretty wild. I'm not gonna lie.
Yeah.
A lot of clinics shut down too, because they were, if you were an outpatient PT clinic, which there's an argument for that too. Like, was that an essential service if you're just working with patients with musculoskeletal pain that could probably wait a little bit? And, was that a gathering? And so those have, by and large, for the most part, opened back up with precautions and stuff. But that's changed too. Like everyone's, distanced, masked up and stuff like that, screened coming into even just an outpatient clinic. So it's and telehealth, like up until recently, I was planning on coming back, so I work in the bariatrics. I have 2 days a week I'm in the clinic, part-time. And, all of my patients were high risk. So I'm like, obesity is probably and physical inactivity, the top two, like, risk factors for serious issues. So like, all right, look, we're not bringing them here, especially since I could do some stuff through telehealth. So I was on telehealth right from like June is when we set everything up. June through, up until now, we had planned for me to go back in September, and then I got COVID, so I was out. But we're back in now and seeing patients, and that's a whole process too. Like, it's definitely changed things in PT, and hopefully, kind of going on the lines of that obesity and physical inactivity and the risk factor angle is getting more patients into wellness activity programs, which is a lot of what I do as a bariatric therapist or bariatric. Someone who works in bariatrics. Is getting people moving more. And I think there's an argument now, a growing argument to get people to address that. Like, I think the reason why our outcomes were really bad here, one of the reasons, is we have a very unhealthy population. We have people who generally don't exercise. 70% are overweight or obese. 41% are obese. And I think physical therapists could play a major role in that, because getting people moving is kind of what we do, right? So
yeah. Now I feel like your specialty in cardiopulmonary PT, I feel like you could have work and research up to your eyeballs for the next 10 years if you wanted with this pandemic.
We are, yeah. I've got some stuff now working with my colleagues in the Army. I'm not going to give away too much, but looking at some of the post-COVID changes, they had some, people forget, like, COVID hit everywhere. It wasn't just like, older people in the hospitals, and it was everywhere. Like our troops, got it too. And, we got to get those guys back and, ready to protect our country and serve our country. So looking at stuff for that.
Did not discriminate.
Did not. And then, working on, we have a small grant that we got here, a pilot grant that was a co-I on, looking at the effects on the cerebral vasculature as well as some other things here. So there's, I was at the forefront of this, like, man, as someone in this area of research, this is kind of like a gold rush for me, because this is like what I do, and the populations who are at most risk are like the populations I specifically research and treat as a clinician.
Yeah.
But it's also a bit melancholy because like the reason why like is the pandemic. It's So it's it's definitely an interesting area, and around the world, the big difference between the states here, you have respiratory therapists, which were huge in this pandemic. Everywhere else around the world, PTs actually do all the respiratory care. They manage the events, they do the ABGs. Only in the United States do they not. We will help with maybe suctioning and stuff like that, secretions and airway clearance and stuff like that, respiratory muscle training, but we don't manage vents, which, there's a conversation now about getting PTs because our training is far advanced beyond most countries, yet our scope is a little bit limited compared to other countries.
Right.
So there's a conversation about getting PTs, trained to do that or added to our scope of practice. Whether it's through a residency training program, they have specialized training because, there probably will be another viral pandemic 10 years from now that we need to be able to have staff to manage it. And they're,
I think you're absolutely correct.
Yeah. Because what they were able to do in England, they were able to pivot a lot of their, in Brazil, they were able to pivot a lot of people who were in outpatient settings to the hospital to help manage the events because it was part of their training still. We don't really have that. And if we lost a respiratory therapist in an ICU, like you're hurting, right? Big time. So
you're not kidding. Yeah. So if anybody wants to look up your legendary work, if they want to find your not your credentials, but just all of the great things that you've done, is there any aspiring DPTs? Is there anywhere for them to find your information or your work that you've done, your research?
Yeah, I think it's kind of funny. I used to do this when I was younger. I used to Google my name and see who would show up. Honestly, if you just Google my name, there was a guy named Rich Severin who was, I guess, like a banker, and he was like involved in some like scam, some like embezzlement thing or something like that. And I finally have overtaken his name because I have a big enough, I guess, social
top
imprint.
Of the search. Yeah. Top of the Google search.
Yeah.
That's awesome.
But even just that, or social media, like I've got a pretty decent following on social media, especially within my profession. And all the accounts are pretty much the same. PT Reviewer, same on Facebook and Twitter. And then
no underscores or anything, just PT Reviewer.
Yeah, on Instagram, it's PT_Reviewer because someone inexplicably took that name. They don't even use it. So like, I don't know if I can buy this account or not, or something like that. And then I've got a few podcasts that I've done for people, and then I run my own. So I'm the associate editor for the Cardiopulmonary Physical Therapy Journal, which is the official journal of our academy. There's Academy of Cardiopulmonary Physical Therapy. And I'm the host of our journal's podcast. So we publish about monthly. With getting COVID myself, like that kind of threw a wrench in our plans. But we'll be having some stuff come out, January, February.
You have to eventually stop moving, or actually maybe not, because I feel like you do so many things that if you stopped moving and grinding, you would probably die. But I feel like you do 9 million things. So if they look up Rich Severin, chances are they're going to find you. Yeah, it's a creature of habit. I was thinking about this the other day. It's I've always been doing a million things since I was a little kid. And I just seriously, it's hard to break that habit. I think I'm getting better as I've gotten older at saying no. And I've had some mentors of mine say, hey, you can say no to these things. You don't have to say yes to everything. Enjoy your time off. Yeah. Kick up your feet. Go to relax. The beach. Yeah. I hear you. So anybody that's listening, that's interested in becoming a DPT, obviously it's intense. It's a lot of training, but it's also very rewarding, really, really interesting. And there are so many different things that you can do with your DPT training once you finish and you become a doctor of physical therapy. So any advice for anybody interested in becoming a DPT, because you're not only a practicing clinician, but you're also an educator. So I think your advice would be good.
Yeah, the biggest thing is, if you're interested in pursuing, a DPT, I literally had just spoken to a potential applicant, was looking at programs that, reach out to programs or like get some observation. You'll need them anyway to apply, but it's tougher now with COVID, but get some observation hours, just get a feel for what PTs do, and across a bunch of different settings. Like, don't just, if you can, and it's even harder now, but like get some observation hours in a hospital or in a skilled nursing facility or in home health, like if you're able to.
Right.
Like where PTs work in every single setting, in medicine, there's if there's humans or if there's patients there, like PTs are there too. Right. So if you've got an interest, like check it out.
Put yourself out there. Just reach out to a DPT.
And the American Physical Therapy Association, our professional organization, so they've got a lot of resources specifically for potential applicants or students, and like great directories as well to like find programs that are nearby you. So
is that apta.org?
I believe, .org. Yeah. Let me double check. Actually, I can't remember if it's .com or .org. Yeah, .org.
And that's the American Physical Therapists Association?
American Physical Therapy Association.
Therapy. Okay. Awesome. So check out apta.org. Reach out to a DPT. Get some contact hours if at all possible, and see if it's something that interests you. Yeah.
And the other thing I'll add too is within the APTA, there are state chapters too, and districts within those chapters. So, I'm a member, for example, of the Eastern District of the Illinois chapter of the American Physical Therapy Association. So, there are local organizations, which you can find those on the APTA's website, that connect with people within your area. You can even go to a district meeting and just like learn a little bit about it, network, and meet people who are in in our profession in your local community.
That's such a good idea. And if they're in Tri-City, they can hit up Rich.
Yeah, I'm our district delegate, so I'm our rep for
go see the legend himself. That would be awesome. Dude, thank you so much for coming on. Seriously, I think you're definitely a nice, interesting episode. Because again, I don't think people know what DPT means when they see the abbreviation, and I think they need to. So thank you again for joining me. I really appreciate it. I would sit and talk for another 2 hours with you, and you probably could, but I have to go to work tonight.
Yeah, well, have fun, man.
Thanks so much for coming on, Rich.
Yeah, no worries. Hey, Tim, and great job with the podcast, man, and keep up great work.